microphone, so we're going to have to be a little bit loud here. So Jennifer's going to report from her group.
We talked about the credentialing issue, and what we decided that, first of all, it's a concern. It hasn't, as far as we know, it hasn't become a real issue yet. But I think the longer that we all practice in this manner, it will become an issue. And you know, we echoed, I think, what Chris said, is that as a group, we need to come up with our own solution to the problem and present that to ACOG before they decide what the solution is and present it back to us, because it may not be what we want to hear, or it may not be in our best interest or take into account what our job as OBGYN hospitalists are. And we also talked, and I'm sure we'll hear from the other group, but we talked about, you know, what do you do to yourself if you call yourself a laborist and you work only as a laborist? What kind of career choice is that, and what kind of path do you go down if you limit yourself in that way? And that can be very, I think, problematic for us. And we talked about probably the way to look at it is through activity units, and quantifying the amount of activity that we have in the hospital as a way to get ourselves credentialed. And you know, it's problematic because every hospital in every state has a different requirement, and where one hospital might require 5 GYN cases and not define what those are, another might require 23 GYN cases and again not define what they are, so you could never do a hysterectomy but still get your core GYN privileges. Now, should you? That's, you know, a question I think that, you know, we all need to take on and discuss.
Okay, we have 1 minute of discussion about this topic. Anybody else want to chime in?
Well, I would just say I think this is coming upon us faster than you had suggested. I think I heard you say this wasn't going to be upon us for a while. Joint Commission basically is requiring us to do ongoing professional practice evaluation and to look at practice volumes. And I've hired experienced OB-GYNs, but in 2 years, when I re-credential them, I'm going to have a real heartburn around their laparoscopic vaginal hysterectomy and other privileges that they came in with, because they won't have done any. So it's coming up quickly.
I agree. I have a sense of urgency about it. All right, let's go.
So we were trying to just sort of come up with a definition, and we threw around a lot of terms that seemed important to people, and we kind of voted against others. Intensivist was brought up for a while, and then we thought, well, we don't want to compete with critical care providers, and we don't want to advertise ourselves as being able to manage ICU patients. Safety officer was another, and that might be something that gets included in some of our core competencies. But what we really wanted to make sure is that we wanted to have the term be open, so we decided to call ourselves OBGYN hospitalist. And we even crafted a sentence which is probably going to be revised again and again, but an OBGYN hospitalist is a predominantly hospital-based, board-certified OBGYN who is an expert in the care of acute obstetrical and gynecological patients and who possesses the OBGYN hospitalist core competencies. And then there'll probably be further sentences that sort of describe what those core competencies are. And they include the kinds of things that, Chris, you were talking about, potentially having certain credentials, certain safety measures and things like that.
So are you saying that if you're board eligible, you can't be a OBGYN hospitalist?
Well, you know, one of the things that came up in conversation and that seemed to be common is that those people that came straight out of residency, at least anecdotally, didn't seem to sort of do well in those programs. I can think of a few, somebody in the program that you and I have both worked at Sacred Heart, who came and left, and there was somebody that mentioned a few stories of people that came and left, and then there was another individual who talked about how at his program they actually have a requirement that a person have at least 10 years of experience in it. I know with my job, they really didn't want somebody who wasn't board certified and who hadn't had at least 5 years of experience. So, I think board certified is unless we no longer are going to be able to be board certified. We'll have to certify ourselves.
And we want to make sure that's state.
But it certainly was a controversial point.
Used to be board certified.
Defining and a question about inclusiveness and getting people to the table, and a question the definition, is people that are in-house, taking in-house OB coverage, should they be part or considered hospitalists even if they also work outpatient? So if you're a hospitalist and you work an outpatient job, and then you're looking at, well, Kaiser physicians, if they're working 3 or 4, 12 or 24-hour shifts, part of their job is the same thing as you're describing, acute care, emergencies, dealing with all of this stuff. And why don't we have them, I mean, loosely defined, they're doing the same job.
Yeah, I don't have personally, I don't have a problem with that. I think if somebody is functioning as an OB hospitalist, OBGYN hospitalist, they are an OBGYN hospitalist at the time that they're doing that. But if they're in the office at another point doing pap smears, and obviously they're not functioning as an OBGYN hospitalist at that point, it doesn't change that they function in that way at certain times of their job.
I just think you have a larger group than the numbers that we're counting when you really think about the job.
Go ahead.
How can you sell this as providing excellent, immediately available obstetrical care if you're in the OR doing an ectopic for 2 hours?
Yeah, that's, my prejudice is we shouldn't be. My prejudice is the obstetrician should
be doing that.
Yeah. Obstetrician should be in labor living. They should not be doing GYN ER. And in both of my hospitals, Sacred Heart and Bellingham, we don't do any GYN ER. And I think that's the safest. Now, is it practical? In some places, maybe not. But certainly, that's the safest. Go ahead.
At our hospital in Memphis, Tennessee, that was something that when we were establishing, my name's Arthur Townsend, that was one of the really big things we had lots of discussions with administration about, was that very thing about ectopics and GYN coverage. Of course, the OB and GYN physicians in the department wanted us to cover the ER for those things. But at the same time, our program, as all of our programs, are so focused on patient safety, being there in the emergency, being the first responder, being there within minutes to prevent a bad outcome. That was contrary to that. And the hospital had to decide what was going to be. We knew what our mission was. They had to decide what theirs was going to be for having this kind of program. And after a couple of weeks of hard discussions about that, they decided they really wanted us there to save the patients and not just to do some ER work.